I'm recording. And I think what I might do is just switch my chair here so you don't get this back. I have a beautiful, beautiful view that I don't think, oh, there you go. So that mountain that you see behind me is Mount Tamalpais.
Oh, yeah.
Which is the mountain in Marin, incidentally, where mountain biking started. But I am going to move my seat so you don't get the glare from the backdrop of the window. Oh!
Shoot.
Somebody's giving us feedback. Do we know who the feedback merchant was?
Two people just called in on the phone.
Okay. So, who just called in on the phone? Would you like to identify?
Yeah, Rick John Appler. Can you hear me okay?
Oh, hold on a second. John Appler. Say hello, John.
Yeah, hi. Can you hear me okay, Rick?
We can hear you. So John Appler's on number 5. And I think what you've got to do, John, is mute your computer.
I did that. I apologize.
Great. Thank you so much. And caller and Dennis Correa, is that you that I hear?
Yeah, it's me on the phone.
Okay. Number 4 is Dennis Correa. Caller number 4 is Dennis Correa.
Got it.
And what's the temperature? What am I missing?
Oh, about today, high was only 82.
Oh, nice weather. Okay, well, it's been clear and sunny here all day, but chilly. So, but I actually got out on the water, which was great. So for me, it wasn't so bad. And yesterday, that mountain that I showed you, Dave and I rode to the very top of the mountain. So we've got up to the top, to that peak, almost to that peak. He wanted to go to the peak. I chickened out, but we were about half a mile short. And I said, no, I've had enough.
Yeah.
And I was cold. So that's what we did. Okay, so let me read off my list. I think we've got everybody. So we've got Jake, Sylvester, Jim Harrington, Professor Jim Harrington, excuse me.
Sure.
Peter Kafka, Jay Krugman, Joel Blanchett, John Appler, Spokane Gary, Ken Anderson, Jim Cameron, and Dennis Correa. Have I missed anybody? Okay. So we've got everybody, and we're a known group to each other, which is very good. I don't know who else might join us down the road, but everybody knows everybody. Nobody new. So I'm going to go straight down the list right now and see who would like some time today. I know a couple of people do. But this might be an easy meeting and an enjoyable meeting. We can just talk about a few things. I have one thing on my mind, which I think everybody will have an opinion on if we want to discuss. So, Jake, let me start with you. Do you have anything you'd like to raise for the day?
Not tonight, Rick.
Okay. Sylvester, anything for you?
Not for me, but I do have a quick question near the end of this call.
Well, we'll give you that quick question probably early in the call because I'm going down the list and we have plenty of time. Jim Harrington, anything for you?
No, not tonight, Rick. I'll listen.
Okay. Peter, anything for you? Peter? Do you have anything you'd like to talk about tonight? I see that you're muted. You need to unmute yourself. All right, we'll come back to Peter in a minute. Jay Krugman, anything for you?
Nothing this evening, thank you.
Okay, Joel Blanchette, anything for you?
Question.
Joel, anything for you?
Just a question. Just a question.
Okay, we'll give you a question. John Appler, would you like to talk about anything in particular tonight?
Well, Rick, if we get into it, I did meet with Barry Tong, a UCSF genetic counselor at Peter's urging, and got some good feedback about some tests. If we get into that area, I'd be happy to comment.
Yeah, no, we'll talk about it. We've got plenty of time tonight.
Okay.
Gary, anything for you?
Yes. I have a question after a while.
Okay, we'll stop by you. Ken Anderson, anything for you?
Nope, not tonight.
Not tonight? We haven't heard from you for ages and ages. We would like to know how you're doing.
Well, I can elaborate on that if you'd like when you get back around to me.
Okay, we'll stop by. We'll stop by you. Jim Cameron, do you want to give us an update on how you're progressing?
Well, there's not really much new, Rick.
Okay, well, we can talk a little bit. You can just fill the guys in on. They haven't heard from you really since you started your chemo, so tell them. We can tell them what's going on. Dennis Correa, anything for you tonight?
No, not tonight, Rick. Thanks.
Okay, and then I see Eric is with us. And Eric, what is going on? What do you have there on your face, man? Oh.
I fell down.
Oh, Eric. All right. Well, we'll check in with you.
Rick, I'm back now. I had the phone on mute because someone had called me.
Okay.
So I'll talk for a few minutes at some point later on.
Okay. No, we'll come down to you. I've got you. And then
we also have Bill Franklin. Rick.
I see. Yes, I know that. I've got. I'm just writing Bill down. Bill, anything for you tonight? Bill, he's muted right now. You would need to unmute. Well, I'll check in with you later, Bill. So, do I have everybody? I think I do. So we'll come back to Bill Franklin momentarily when in between people and see if he needs any time tonight. So Sylvester, tell us what your question is. You never have a question, so we should give you some priority.
Well, it won't take that long.
Okay.
I noticed when I phone in on a Tuesday.
Yeah.
I have not quite understood because I listened to the caregiver phone calls also, but I haven't been able to figure out because according to the printout I got from the computer, the high risk recurrent advanced men meet on the first and the third Mondays.
Correct.
And the care providers meet on the first and the third Tuesday.
That's right.
But sometime when I call in, I thought on Tuesday, I also hear the high-risk people talking.
Second and fourth Tuesdays.
Okay, so that's what it is.
Right. So on the second and fourth Tuesdays, the high-risk advanced people call it. Our call is at 3 o'clock your time.
Okay, so it's 4 times a month then instead of twice for the high risk.
Yes, every
I didn't
week.
realize that.
Yes.
Okay, I didn't realize that.
Okay. Now,
yes, indeed.
Just a heads up, it's not coming up too soon, but Rob, bless him, has done the calendar, I think, until the end of 2019. And we know that there are going to be a couple of months where we have to screw around with the calls because it happened once this past month. We would finish up getting high-risk calls on successive nights. So we would have a call on a Monday and a call on a Tuesday. Because there's 5 Tuesdays in a month, it screws us up. So I'll give everybody a decent heads up warning about how we're going to change meetings when it comes to those months. I can't tell you what they are off the top of my head. I think Jake and Peter know, and I don't need to tell you right now, but there's nothing that's coming up too soon. Rob also told me there's a couple of meetings that fall on major holidays like Christmas Day and what have you, so we'll have to decide. We'll decide communally whether we want to have a meeting on those days or not. There's one meeting, well, there's an inner conversation meeting that falls on Thanksgiving, and we will not hold that. But as far as meetings on Christmas Eve, Christmas Day, we'll ask you first how you guys feel, if you want to pass or you don't want to pass. So, okay, Sylvester, have we clarified for you?
Yes, thank you very much.
Pleasure. Okay, Peter, you have the floor.
Okay, I think many of you know that last Wednesday morning, I got a call from Mike Tamalies, his wife C, early in the morning, 6 a.m. that Mike had passed away during the early morning hours. It did not come as a surprise to me. We put him on hospice 2 weeks prior. It reached a point where his oncologist felt there was nothing more he could do and told us that the next step would be hospice, that it was really going to be pain management at this point, that he wasn't going to be a candidate for chemo, and so he was taking off all his meds at that point. And he was in rough shape. His metastasis had spread beyond the bones to the liver. His PSA was rising rapidly, about 1,000 points every couple of weeks, and he made the best of it he could. I mean, I think he knew what was going on. He knew well what was going on. He tried to keep a positive outlook. We talked about building a wheelchair ramp to his house, and I had that set up to do this past weekend, but he had to cancel it because he was already gone by that point. Yeah, there's some lessons to be learned. I know I'm still working with it a little bit. It's always a difficult thing when you lose somebody that you've been close to, and you realize that this, in the advanced stages, is a killer disease. And yes, we can prolong the inevitable in some situations and eke out some more months and years and so forth, but it's not a fun prognosis. And we stand together with each other and help each other and support each other as much as possible. So it's shaken me up a little bit. One of the lessons I learned is to be a little more proactive with people in terms of helping them kind of really think through the final arrangements with their spouses and their family, particularly if their spouse is not an organizer or fighter herself. Because there's a fair bit of work to do. I mean, his wife, his widow, I guess, is only 37 years old. She's never had a credit card in her life. I mean, they managed everything with cash and kind of kept pretty low key, low profile. So there's a fair bit of catch up work that needs to be done. And as you all know, sometimes in advanced disease, you're not thinking straight all the time. You're missing some beats and not able to manage all things like you used to. So it's just a lesson I learned that maybe I should be more proactive and should have been more proactive in helping make sure everything was covered so the transition was easy. So that's essentially it for me. You know, I think the doctors did what they could in this situation. Perhaps his first oncologist could have been a little more on the game. When I got into it, I think we realized that and we switched oncologists, but things had proceeded and progressed too far along to really make a lot of big changes. So I'm not blaming anybody, and I think we managed it well. But it's always sad. So I just wanted to say that it's shaken me up a little bit, makes me think about my own disease considerably more. Even though I am at this point not metastatic, I know that could happen at any time, and it's scary and frightening. So that's kind of where I am right now.
Peter, this is Jake. I know that you did an awful lot for Mike. I know you worked with him, numerous times. You went with him to the doctor. You set up things for him. You were proactive. You did as much for him as he could have done for himself. So don't feel that you didn't do everything you could. You did. And I said that in the email. I think I can speak for everybody here. We all felt for Mike. He seemed like he was kind of like a lost bird. He was kind of like didn't quite know what to do, no matter what Rick told him or what you told him to do or suggested to him. It just he had a hard time dealing with it, I guess. But that was not your fault by any stretch. You did everything you could, more than most people would have done. So God bless you. God bless you for what you did, man.
Peter, this is Jim Harrington. There's a lesson here, it seems, that you brought out, that Rick brought out, and that is the lesson or the question about quality of life versus quantity of life, which in listening to Mike so many times, he chose, if I'm not mistaken, quality of life and refused to go into chemo, which might have prolonged his life. But it's an interesting question. I don't know, Rick, if this is something that we talk about. I mean, each person makes their own choice, but I don't recall people making a choice for quality over quantity.
So Jim, I'm really pleased that you raised that. First of all, I want to say, before we get into the quality-quantity issue, because that was the subject that was on my mind that I mentioned 15 minutes ago, that I really wanted. I thought if we have time, we might want to talk about that.
Oh, okay. Good question.
We can spend 20 minutes on it right now because I see, we have the time today. So that was exactly. But before we move forward, I also want to put in a vote of appreciation for what Peter did. I mean, it was extraordinary. And Peter, I don't see any way that you can beat up on yourself for not having brought Mike's attention to certain factors. I know for a fact that whether you recall it or not, you did bring his attention to his arrangements, because you and I talked about it. And Mike didn't want to deal with it. There was a lot of things that Mike didn't want to deal with. Now, if he doesn't want to deal with those issues, it isn't up to us to do it for him. I've had this discussion with maybe 3 or 4 people in the last 5 or 6 days. And somebody said to me yesterday, I think it was Dave. I think Dave and I were talking about it here last night over dinner. And as Dave said, people have to be responsible for their own disease. And we as advocates can bring them, we can bring them to the water, but we can't force them to drink. And Peter, you brought Mike to the water time and time and time again. I'm sorry, Dave's Stella. Shh, good girl. So I just cannot accept that you didn't do everything that you needed to do. And I don't think you should be beating yourself up. At the same time, I do want to talk a little bit about this quality versus quantity, because I've been talking about it with a whole bunch of people recently. I just opened this book that I mentioned, this The Scalpel and the Soul, which is a decent read. You know, I'm not saying everybody should go out and buy a copy, but if you happen to get your hands on a copy, it's very interesting. It's by Alan J. Hamilton, who was the chief of surgery at University of Arizona. He's very close with Andy Weil. He's very much interested in integrative medicine. He has a spiritual side to him, and the book really integrates the medicine with the spiritual, as you can tell from the title. And at the end of the book, there are 20 life lessons, of which I've read about 6 so far. But his rule number 3 is never trade quality for quantity of life. And I don't know that I agree with that. In fact, earlier on today, I was over in Berkeley meeting with a woman who, God willing, will moderate a U.S. breast cancer call for us. I'm almost certain this is going to be a go. I'm really excited about this. And this is a woman who is triple negative, has been fighting breast cancer for 10 years. And we talked about this quality versus quantity issue. And I think that in many cases, it's worth considering sacrificing quality for a short period of time if you think it's going to restore quality and quantity for a decent period of time. And that's really the trade-off. It's not quality versus quantity, it's quality versus quality and quantity. And it's an issue that I'd like to throw on the table. I'd like to hear what other people think about it. And most of you who are on this call today have had to make this decision of quality versus quantity. So tell me, you know, let me throw it out. Let's maybe get a discussion going for the next 20 minutes on quality versus quantity.
Well, Rick, I can start with Jim Harrington. I've always thought about quantity, and because I just want to go a long time. But I haven't really dwelt much on quality. Often the quality issue will come up when you start to really decline. And Mike was a special case. I know that he didn't want quantity, but my thinking is I want quantity. I want to go as long as possible. But then again, if it starts to get really bad and I start to get into bad shape, I guess quality would obviously come along toward the end. Initially, I'd go for quantity.
Mm-hmm. Who else would like to comment? I mean, we've got people like Eric on the call who is wrestling with this issue constantly, and others of you, and Jim Cameron, who is getting to understand this quality versus quantity pretty well, and others of you who have been through chemo like Dennis and have had to make the decision. Speak up.
Yeah, this is Dennis. It is a very personal decision, and it's the way I look at it, pretty much dependent on the individual's life that he has right now, including his spiritual life and how strong that might be, and the people around him, the family members and other people that he enjoys being with. The physical condition of the individual outside of his prostate cancer, how debilitating those things might be. That's kind of the way I've looked at it. And I totally agree with the quantity. I don't think you can have the quality without the quantity. And when it gets to that point where the quality is declining so much, then you can change your decision. But I think initially, especially now that there is so much research going on with new stuff that's coming out all the time, you know, my hope is I want to be around long enough for some of this new stuff that I might be able to use to apply to me.
The issue with Mike Tamalies from the very outset was almost that he didn't want to acknowledge that he had a killer disease. I mean, Peter knew him before I did, but even in the earliest times when he came to our call, which was probably back in, I don't know, I'm just looking here. I can't really tell from my notes, maybe 2000, maybe it was 2 years ago, 2015. You know, it was always that he didn't want to commit to do anything. He didn't want to commit to do the exercise. He didn't want to deal with the second line anti-androgens until he absolutely had to. It came up this morning before my meeting with Tonya. I had a call with a fellow in Yarmouth, Maine, who called me early this morning, and I've worked with him before. He's been on our call, and he just got diagnosed with he has recurring disease, and they just did one of these F18 pyrate, I think it is, or I think it's pyrate, scans, which are the best scans that are available, and they found a met in his femur, and he's wondering what he should do. Should he do nothing? Should he do spot radiation? Should he do, one of his doctors suggests that he do hormone therapy. I said to him, if it were me, I'd dive right in with chemo. If you're committed to do everything that you can, we've seen enough evidence that early chemo makes a difference. And I can only tell you what I would do. But that was never what Mike Tamalies was committed to. He was not really committed to do anything that alleviated the disease, and we had to pressure him, even if it was just to do some exercise. And so I think you've got to buy into the program if you have serious disease. And if you don't buy into the program, you can't really expect for the disease to be alleviated. When I say alleviated, we know that for most of you, it's not curative. But you can manage this disease for a very long period of time. But if you want to manage the disease for a long period of time, you've got to do things that aren't comfortable doing. Jim Harrington had to get into that listeria trial. Was it good? Was it a decent experience? No, it wasn't. It was a crappy experience for Jim.
It sure was.
But he was committed, and he was willing to do it. And more power to him, and more respect to him for willing to do that. This was something that, and I'm just stating facts, this was something that we could never get Mike to buy into, to go the extra yard. And when and everything that Peter did, Peter was wading upstream. And I just want to urge you all to look into your hearts, to decide how you want to deal with this disease, and then to follow that path. You can always change the path. But if Mike Tamalies or other people who are on this call decide they don't want to fight the disease, we have to respect that, and we have to go with the program. And me especially, because I don't like to see anybody not take advantage of all the disease, all of the treatments that are out there. It hurts me. I personally think that if Mike had done chemo much earlier in the disease path, he might be still with us today. But that's my own personal opinion. It wasn't something he wanted to do. I have to respect that. So again, Eric, are you with us? Let me see. Are you there, Eric?
Yeah, I'm here.
Okay. What are your thoughts on this quality quantity issue and making a commitment to fight the disease?
Oh, I'm all for quantity at this point. You know, each of these drugs, you know, when I'm on a 10th drug or something, each one promises a couple months or a month or 6 weeks. I'll take what I can get.
Yep.
Well, God bless you.
Hoping,
I think that's the bottom line, Rick.
There's been so much advance. You distributed that talk from Dr. Agarwal. I'll keep moving on. I just started Wednesday on Redcana, docetaxel. So far, so good.
Okay.
Some side effects, nothing like the docetaxel, but it's still early, so hard to tell. Okay. But I'm carboplatin as well. So,
Well, we'll come back to you. We'll definitely come back to you on your treatment because I want to learn a little more about that. But I think you've said something really important, which is that for you'll do everything you can to stick around. You're committed to be here, and we see that in the treatment paths you're taking. John Apley, you wanted to say something.
Oh no, Rick, I just think that the last caller said, we're on this call because we are fighting, and there is so much new happening that we can take advantage of if we can stay around long enough to do that. And I think you have everybody here in this call who does want to fight on, Rick, and we understand that when you don't, you give yourself, you give in to failure. But I think you can rest assured that we all want as long as we can get, and only in the last stages do we have to make that trade-off you're discussing. And we'd rather focus on the optimism of what's out there to help us now.
Who else? Jim Cameron, what are your thoughts?
I'm going to push as hard as I can. You know that, and I'm doing whatever they tell me to do, whatever they think will help me, and I'm going to keep pushing and hoping that my other problems don't drive me into the ground. My rheumatoid arthritis and my eye problems.
Ken Anderson, we haven't heard from you. Are you still with us, Ken?
Yeah, just for a moment. It's a tough topic for me in general. I mean, I think it's still too new. And I think I'm not going to say I'm done fighting or anything like that, but I don't any. I don't know.
We're losing you a little bit, Ken. You're cutting in and out on us. Maybe you're in a bad place in that beautiful new house of yours.
Well, I'm trying to say that, it's still pretty new for me, so I don't really have any comment. It's a hard topic.
Right. Okay. I mean, I think we don't have the best reception from Ken, but I think he sort of got the gist of it. And I Ken to me is quite special because I remember, as some of the rest of you do, how devastating the diagnosis was for him 8 or 9 months ago, whenever it was. And what I see in Ken is a significant turnaround in how he's going to deal with this disease. I'm sure the fear is an element, but I don't feel the fear when I talk to Ken anymore, whereas I did at the beginning. And I think, he's bought into the program. He's going to do whatever he's got to do, and he sees that we can stave this disease off. Who else? Paul Frieda, do you want to say anything?
Yeah. Well, I had a couple of thoughts. The first is, I think in general, everyone wants to live as long as they possibly can. And there's a mantra in athletic competition that you never, ever, ever give up. And the reward is that sometimes you can pull out a win when it went like it was impossible. So that's good to keep in mind. But on the other hand, I think that if you're in so much pain that the doctors cannot relieve it, and you're burdening your family, watching you, let's say, bedridden and in constant pain, there comes a point where maybe it doesn't make any sense to hang around anymore. But I don't know how, what percentage of guys face that kind of thing where the doctor really cannot relieve the pain and you are immobile. So, but it seems to me if you get to a point like that, it might not make sense to hang around anymore and burden your family.
Who else has something they'd like to say on this?
Yeah, this is Peter. I'd like to make a comment again that most of us have really good oncologists and who are on top of their game. Many of us do. Not every one of us does. In this situation that I was working with, it wasn't just Mike I was working with, but his doctors as well. And when you get further out into the hinterland, which Maui still is, not all oncologists, not all physicians are up on all the latest studies and trials and everything. And you're working as much with the doctors sometimes as you are with the individual and yourself. And it's a matter of educating the doctors sometimes and really getting active as an advocate. And it's a precarious spot, as Rick knows well, and probably all of us know a little bit. That getting in between a patient and a doctor as an advocate and pushing for something that you're not licensed to provide is a tricky place to be in. But in our situation, trying to get doctors to recognize that chemo might be of use early on rather than as a last resort was new information for one doctor in particular. And, hopefully they're changing their attitude now. I don't know. I haven't seen this man in a year, but it's part of our mission to educate ourselves so that we can manage our own disease, but also help educate each other so that we can help each other meander through this. So it's not just. I understand what Jim Cameron is saying, that you got to do. Sometimes you got to do what the doctor says, but sometimes you got to kind of push your doctor and really ask the questions and lead the way sometimes. And it's difficult navigating that one, but we got to do it.
Yeah, well said, Peter. If there's any job that we have as advocates, it's to hold the hand of some of you who are out there and to try and educate you and help you to manage your own doctors. And time again, as Peter says, we find doctors who aren't responsive. Jim Cameron well knows that we had to ask his doctor 3 or 4 times on different occasions to send off samples to Foundation Medicine, notwithstanding that another lead genitourinary medical oncologist had requested that in writing. But the guy didn't feel that it was appropriate, felt that he should be giving Jim docetaxel and carboplatin for 3 or 4 months and then see it afterwards.
Hey, Rick?
Yes, Jim.
That's not 100% true, because he wanted to put his regime in first to get the chemo going. It only took two requests to get him to do it.
Well, I know you asked me more than 2 times, Jim. You and I spoke about it at least 4 times, and finally I said, go in there, sit in his office with him, and get him to do it. It wasn't 2 times. I know for sure.
The reason he didn't do it at first was because he wanted to get me on the chemo, because he thought these tumors were serious enough. They needed the chemo as soon as possible.
Yeah, but that didn't stop. He already had the tissue samples, so we can make excuses for him up the wazoo. But the fact is, we had to ask him 3 or 4 times to do something that other doctors had asked him to do. And,
well, we'll have to
and then when the doctor's office turns around and says they don't know how to order, which was one of the times you asked them and they told you they didn't know how to order the test, you know that the guy's making excuses, and this is what
That's not the way I read it.
Yeah, well, it's the way I read it. When we talk to a doctor and we say, please, can you order a foundation medicine test, and they come back and say, we don't know how to order that test, I don't know how else to interpret it.
They didn't know how to order it. They said they were putting it in.
Before they told you that, they told you the first time they didn't know how to order it. But I'm not going to argue with you, Jim. The fact is that there was some recalcitrance there.
No, because I'm quite happy. I'm quite happy with Dr. Gonder and the Florida cancer specialist.
I know you are, and God bless you with it, and it's your decision. We'll just moving along. Yes, we do have to educate the doctors, and sometimes the doctors don't want to listen to advocates. Who else would like to say something on this issue? Is there anyone else?
Well, I asked my doctor about genetic testing. They said, "Oh, we don't do that here." So I'm going to have to look for another doctor in that regard.
Yeah, this is the sort of issue that we're dealing with. This is the sort of issue that we just faced, and we have to pressure these doctors to introduce them to concepts which are now becoming widely accepted across the board. But not all doctors in community practice understand them, and if they don't understand them, they fear them. I was on a research call last Friday with a very well-respected consulting firm that had been retained by Foundation Medicine, and one of the suggestions I made to them is that Foundation Medicine needs to make a bigger commitment to educate community standard practitioners, because they don't understand the power of the tests that they can run today. And there's no point in an advocate telling them, because they don't give credence to that. But if Foundation Medicine tells them, it's going to be a different situation. So I empathize with you, and I mean, just by the way, Paul Frieda, Professor Bill has said any doctor that wants to discuss the value of genetic testing should feel free to call him at any time. So there's a resource that you can suggest to your doctor. Let them talk to a well-respected cancer researcher at an NCCN hospital or cancer research center who can explain why genetic testing is very important. And I can send you a recent article from Memorial Sloan Kettering that I've circulated to a couple of people, John Appler and others, and Joel Blanchette and others, that shows the importance of getting genetic, germline, and somatic testing. I've made a note to send it to you afterwards, but this is exactly what we're saying. We have to hold your hand to help you educate your doctors. And if you cannot educate your doctors, get out from under them, because you met the enemy. You met the enemy. And sooner or later, they're not going to be with the program. That's my own personal opinion. That's what I would do personally, but everybody has to make their own decision.
And it's true. It's true at every level. I mean, one of the guys on my low and intermediate group, who happens to live here as well, was right at the early. All he needed was a biopsy, and we wrestled with trying to get him to get a multiparametric MRI, and his doctor said, "Well, we don't do that here on Maui, and the only place you can get it done is at Queens Hospital on Oahu, and I have no connection with it, so I don't think you need a multiparametric MRI. We should just do a regular trust biopsy." So he fortunately took it upon himself to fly to California and go to UCLA and set it up himself to get the MRI and follow up with a biopsy. So there are ways around this, and it's not that all doctors are obstinate; they just don't have the resources. Some of them, or the education, or as my girlfriend says, why all doctors graduate with an MD, but why go to a C student when you can go to an A student?
Well said, Peter. Very well said. Anybody else want to say anything on these issues of quality versus quantity, or educating your doctor before we continue on the round robin?
I would like to say something.
Please, Sylvester.
I have not got to the junction yet that I have to make the type of decision most of you have made. And that's one of the reasons I listen to this program, because you're helping me. Hopefully I'll never reach that junction, but if I ever get to that fork in the road, I hope, based on the knowledge that I have gained by listening to each and every one of you, that I too can get over make the correct decision for my future care, like each and every one of you are doing. So I just want to thank each and every one of you for welcoming me, because I am getting an enormous amount of information, although sometimes the medication I don't understand, but I am getting an enormous amount of information that will educate me to make appropriate decisions when my time comes. And again, I would like to thank each and every one of you for allowing me to be in the background listening, because I don't have the experience or the knowledge that each of you have concerning a lot of the different types of treatment that is available. So again, thanks to each and every one of you.
Thank you, Sylvester. So is there anyone else that would like to say anything on these topics before we move on? Feel free. Okay. Well, we, as most of you know, we don't often do this. We don't often pick a subject and we ask everybody to chime in on it. I mean, it's normally much more technical. And I think this has been a good conversation. And I really want to thank everybody for A, contributing, and B, supporting each other on this. I mean, every one of you is willing to support every other person who is on this call. If I called any one of you up and said, A, will you please call B, I don't think there's anybody on this call who would say no. And I think that's what makes these calls pretty special, especially when we've got a group of people that that recur like we do today, and everybody knows each other and everybody knows each other's story. And, you know, that's what a support group means. And that's what we want to do. We want to support each other. We want each other to stick around for as long as they possibly can, because each one of you is important, not just to your own family and your own loved ones, but you're important to us who are on this call and everybody else, and every person that's on the call, and meaningful. And when we lose a Mike Tamales, we all feel it. And, you know, I'm pleased Peter raised the subject, and I hope there are lessons that we can learn from Mike's journey. And I hope that all of you who are on this call will stick around for a very long time. You have my commitment that I'll do everything I possibly can to keep you here. And if you don't want me to, or you want me to back off, you just have to say it. But my nature is to do the very most I can for each and every one of you, and I'll continue to do that. Okay, let's move down the list. Joel Blanchette, you had a question.
Yes, thank you. Real quick, totally off topic here, but you said, of course, I know you went to the PCRI and you also are going or have been to the San Francisco conference. Do you go to other conferences during the year? Can you recommend any other patient-friendly conference?
So PCRI does have, and Peter probably knows more about this, so I'll let him comment in a second. PCRI has spring conference. I think it's only a single day, and they do advertise it, and we will make sure to advise you as soon as that conference becomes available. It might even be on the website right now. I'm not certain. I attend this UCSF conference each year if I can. It's a different sort of conference. It's really a doctors and cancer researchers conference that they open to patient advocates. And I was fortunate enough to first get invited in 2008 and have made some very good contacts at that time. But as I mentioned in my letter, in my call notice this week, it was the conference at which Chuck Ryan stood up and said, well, either we've just got abiraterone approved or it's very imminent. And he told us that this was a drug that addressed the testosterone that the body itself was making. So you could, if you like, be castrate resistant, but the cancer still thrived because the body, the cancer itself, was finding a way to make more testosterone. And abiraterone acetate, or Zytiga, was the first drug to really address that. And he was the principal investigator on the trials that led to the approval of Zytiga. So there's always new and interesting topics that are discussed on at this conference on Friday. If there's anybody that's local and in the Bay Area and would like to attend, I can probably meet you beforehand and walk you in with me. I did ask Dr. Steve if he wanted to come up. I'll give you all later on in the call a quick update on Steve. But it's very technical. So I would say in 2008, I was lucky if I understood 10%. And today I'm lucky if I understand 50%. But what it does for me, and the reason I think it's so important to attend for me personally, is that it kind of points to the areas that are coming down the pike. It points to areas where research is thriving. I mean, this was one of the first places I remember about 3 years ago that I really understood the concept of how the disease changes and what the disease that's diagnosed when you first when you first learn that you have prostate cancer, how different that disease can possibly be to somebody who's in late stage disease. And how heterogeneous this disease is, how different it is for so many different people. So Joel, that's another, this is another meeting that I go to. I know that last year, New Prostate Cancer International, Mike Scott's organization, together with, I lost her name. What's her name, Peter? The woman who he works with now?
Jan Manorite.
Jan Manorite, thank you. That she and Mike set up a Florida meeting. It was just a one-day meeting, I think. But the biggest patient-centric meeting each year is the PCRI conference. So that was a bit of a waffly answer. Sorry about that.
Joel, where do you live?
The Washington, D.C. area.
Huntington Beach?
No, Washington, D.C. area, Peter.
Washington, D.C. area, okay.
Peter, do you want to talk about the second conference that they have?
Yeah, I've never been to it. It's called the Mid-Year Update, and it's usually Dr. Schultz and Dr. Moyad and Schultz usually just share it. I don't think they usually bring in other people, and it's just a one-day affair, a Saturday, and it'll be on their website. They probably already have a date set up for it. It's usually just Saturday at the Marriott at UCLA. I mean, at LA, the LA Marriott. One other thing you might look at, Joel, is there are some support groups that are really outstanding. I don't know any in the DC area, but I know when I was getting treated in San Francisco, I took the train down to Mountain View, where just a couple of times to go to their support group down there, their Us Two support group, and I was really impressed with the knowledge that those guys had. So that was a couple of years ago, or a year and a half ago. So sometimes things like that can really inspire you as well.
You should know, Peter, that Joel is actually a support group leader in his local area.
Okay.
All right. Thank you very much.
Pleasure. Anybody else got any suggestions for Joel on conferences? Okay. So let's keep moving down the list here. John Appler, you're up.
Yeah, thanks, Peter. Just on this last topic of, quality versus quantity of life, I'm really sad to hear about Mike, but I remember the story from, Tom Wolfe wrote the book called The Right Stuff about the fighter pilots. And, once in a while, the fighter pilots, one would auger in, they'd be really sad. But the first thing the fighter pilots want to know is, what did he do wrong? And by knowing that, a lesson to be learned, it gave them strength that they could then not make that mistake and gave them hope. And I hope that's a good analogy for, what I hope to get from this group. I really want to, I think that the common learning of all this is that we'll protect all this. And a sad thing about Mike, I think the hope is that we can all learn lessons from all of this and, take it forward. So, yeah, my little contribution was simply, I met with a genetic counselor, and you and Bill had asked about this new impact study that came out from Sloan Kettering. And it turns out that UCSF does have these very broad tests where they can look at 500 different genes and look at your disposition for different kind of cancers. And that is available from them. There's also commercial people that have it available also. Companies, Peter, Foundation One has a test called the Foundation One test. Claris has one. And just stepping back for a second, the genetic counselors that Peter encouraged me to meet with at UCSF are really good. Very well schooled, deeply in the research, very helpful. So I'd encourage anybody who is being, taken care of in the San Francisco area to see a genetic counselor. It's just amazing how much they know about the science and the individual. And they look at your case individually too. And then, of course, as you mentioned, there's a couple tests available, germline tests. One is from Invitae that looks at 52 genes, costs about $250. Another is from Color Genomics, costs $250, looks at 30 genes. What else? We asked him, who are the visionaries out there? What's the new research going on? And companies we should watch or techniques. He says a lot of the excitement is around this circulating tumor cell research, the CTC research, companies like Natera, and also a new hot company called Grail.com in Redwood City. And I said, I told him about our group and your meeting is part of the coming up here, Peter, this week. And he said, absolutely share my name and share my email address and encourage people to reach out. So I just sent his email address to you, Peter. To you, Rick.
Okay. Thanks.
And one last thing, he did point out too that people kind of worry that if you have your genetic testing done, there's always a chance you could be denied insurance. He said, no, there's federal laws that protect that information from denying you insurance, but ironically, it doesn't apply to life insurance. So your life insurance company can ask you if you had genetic testing, and if you did, they have the right to see it. But most times they don't rely upon that. They rely upon your family history and also your personal cancer history.
Yeah, interestingly enough, my buddy Dave Fisher, who I'm staying with right now, and some of you have met because he was kind enough to do the video of the contraption for us and donate his time to video the contraption at PCRI. Just yesterday, I was encouraging him to do genetic testing at UCSF because he had 3+3 prostate cancer. That's how we came to be buddies years ago. And he lost his sister and a mother to ovarian cancer, and I forget what his mother died of, but it was a hormone-based cancer. And I said, you know, Dave, you should just be sure that you're not carrying a mutation. His disease is well under control, but you know, for his kids' sake, it's just worth getting tested to make sure when you've got a family history like that that you are not carrying a mutation. Dennis Correa, what do you have to add to this discussion?
Yeah, that was you know, I had a lot of decisions to make on that thing, but realized that some of these things cross the line between, you know, whether male or female. Even though I didn't have any sons, I had 2 daughters, and so there was a value to having it done there. And because my family history was very difficult to come by, although one uncle of mine had passed away from prostate cancer for a fairly early age. My dad unfortunately died from lung cancer very early. So I just wanted to know if could it be possible that, you know, I was carrying something. So went and did the genetic counseling. They were very good also, explained it, and it didn't cost me anything. Insurance took care of everything, and I got the results, and it was negative for all of them. So it's useful. Then I could tell my daughters, well, you just stick with your standard screening for your breast cancer and stuff, and should be okay. One less thing to worry about for them.
John, I assume that they took the samples to do the testing for you, or is that a bad assumption?
No, that's actually a really good point that you bring out, and as the previous caller did, that in going through my family history, they said you just don't have enough cancer there. You don't have enough instances. You don't have the things we look for. In your case, John, insurance won't pay for it, and I can tell you, there's less than a 5% chance that your sons will have the key genes and be carrying it themselves. So it was reassuring to us that even short of testing, they can examine your history so well that they can give you, in my case, assurances, that make you feel good for going through the process. So that's the other reason I think to talk to a counselor.
Okay. Anybody like to ask questions to? Well, Peter, do you want to talk a little bit about your testing experience with genetic counselors, etc.?
Well, I think I did bring it up. Before and other things. I had to do pretty extensive research into my family. I didn't have a lot of medical history, particularly because it had been years since my parents passed away. But my father did have metastatic prostate cancer, but I was too naive at that time or young to really know all the details. I was there when he died, but I didn't know. I didn't know his Gleason score. If they even had Gleason scores then. There's a lot of stuff I didn't know. So I had to kind of push my way into the game, and I came up with enough information to make the case that they felt it was sufficient to go with genetic testing. And as you know, as most of you all know, that what came up with me was a mutation in a gene that's got some link to prostate cancer, but it's not a major link that they know of yet, at least yet. And that's a gene called MSH6. But it does point to one of the major genes that gives you a proclivity toward colorectal cancer. And they said it puts me in the 50% bracket for possibility of colorectal cancer. And what came out of it was the recommendation to get a colonoscopy every year rather than every 10 years. So it was useful information for me and for my sons. And I can't make them do something about it, but I passed all that information on to them.
Does anybody have any questions who hasn't spoken? Do you have any questions about this, about the genetic testing?
Yeah, I have got one. How does the Polaris test compare with your Gleason score? The Polaris test, as I understand it, measures the aggressiveness. How do the two compare? They complement each other, or what?
From my understanding, I had my Polaris test from my tumor done right after my surgery, and it's usually, from my understanding, I might be wrong in this, it's usually a test that if you go for a prostatectomy, that the surgeon will send in for to get an idea of what the percentage or possibility of reoccurrence is going to be. When they talk about positive margins and negative margins, if you've got a high enough Gleason score and there's a good possibility that you're going to need radiation later down the road, the Polaris test kind of lets you know what percentile you're in, that there's a good likelihood that you will be needing further treatment. I mean, Rick, you probably know more, but that's my understanding of it.
No, I don't. I mean, my understanding of it too is that it's a test used post-surgery to predict the likelihood of recurrence. I don't know the formula. I don't know how they come up with it, and I don't know how it correlates with Gleason. I'm sure there's probably been studies done, and I'd encourage you, Paul, to go to somewhere like PubMed and just put in Polaris and Gleason and see what you come up with, and maybe you can tell us if you learn anything.
Okay.
Does anybody else have any information on Polaris?
On tumor testing in general, Peter, I could make one comment. The good news is they keep the tumor samples around forever. They seal them in wax. The bad news is, as far as the biopsy level, apparently there's not enough tissue there to actually do the somatic testing that you need to, actually have a prostatectomy to be able to have enough tissue to do the testing.
Well, I mean, you can do testing from biopsies. There's no question. I mean, I know plenty of people that have had biopsies and they've had the somatic testing done. So I'm not sure I quite follow that, John. But
honestly, he wasn't sure about that point, but he thought it took a lot more tumor. Yeah.
No,
okay.
I don't. The answer is I don't think so. I think that if there's a biopsy done, whether it's a bone biopsy or a soft tissue biopsy, that produces sufficient tissue in order for tests to be run. Now, Guardant, for example, I believe is all done on a blood test. I think the Guardant test is just done with blood. I'm not certain about that, but I think so. The Foundation Medicine is, they have the option of either a liquid or a solid biopsy to analyze. So,
and that's for a tumor analysis, right?
That's for a tumor analysis. Yeah, that's exactly true. That's for a tumor analysis. But then, the question is, does the tumor analysis include inherited mutations or all the inherited mutations? And that's what the discussion with on that Memorial Sloan Kettering piece that I circulated was about. That Memorial Sloan Kettering is now doing a single test that seems to cover all of the inherited mutations as well as most of the major other mutations that might lead to identifying an actionable gene.
The way I'm reading it is that the comment you made is that perhaps the initial diagnostic biopsy, particularly when they do blind biopsies, might not produce enough tumor tissue to start doing somatic testing, because most people, when they get somatic testing, are going back into a known tumor site and getting tumor tissue of some kind, or blood tissue or something from the known disease, whereas the initial diagnostic biopsy might not produce enough. That's just a wild ass guess on my part. I might be wrong on that.
Mm-hmm.
Yeah, that's a good point, Peter.
Okay, so we'll move along here. Before I do that, Bill Franklin, if you're listening in, did you need to any time tonight?
No, I'm back, Rick. I don't really need anything tonight. I'm just listening in. So
Okay, thanks.
Everything's cool over here.
Good. Well, we called on you before, and you weren't there, so I said I would make sure I would check in with you again.
I was chasing a lizard out of the house. Nobody else here will go near it.
No, you know, these are important functions. These are very.
That's right. That's what Daddy's for.
That's what Daddy's for. I thought 9-year-old boys were very good with lizards.
Oh, he wasn't around. My daughter wouldn't touch it. So.
Okay. All right. Let's keep moving down the list. And
Rick, Larry Fish has joined us.
Oh, okay. Larry, do you need time tonight?
Hi guys. No, I'm okay tonight. Thanks.
Okay. Larry, listen to the recording, because we spent the first 40-odd minutes or so talking about some very interesting topics. So I'm not going to recap it all now, but we talked about quantity versus quality and educating your doctor, and I think it was good conversation. So it's worth. You might find it interesting to listen to. Okay.
Yeah, I'll go back when I get a chance. Thanks.
Okay. Let's see who's next up. Gary.
Good. Okay. So I had my 10th month appointment to see my urologist, and my PSA has risen. So it went from a 0.01 6 months ago, and now it's up to a 0.04. And he said, this concerns me. So if this turns into a trend, I think we need to talk about the next step in the process. And so I thought to myself, well, when if cancer has somehow metastasized, it's gotten out, and it's so small, how do you find it? And I mean, where do you go from here? I mean, you know, what do you do from at this point?
Would somebody who has wrestled with rising PSA and recurrence, would one of you like to answer, Gary?
Larry, did you say?
Gary.
Oh.
No, I'm saying there are some of you on the call that have had to deal with your disease coming back and rising from an insignificant level to a significant level. And you know, how have you determined what to do and when to do? And does anybody want to discuss that? I can jump in, but I'd rather get some direct experience from some of you who are on the call that have had that issue. I mean, I'm not going to call names yet.
Rick?
Yes.
Okay, Gary, I've spoken quite a bit, Gary, but I'll speak up a little bit. You've had a prostatectomy. You have not had radiation, correct? You've just had a prostatectomy, right?
Right. That's exactly right.
Yes. So what's going on is this is not unusual. This is kind of it's kind of a lead-in from what what Jake was just asking about the Prolaris test. You know, many of us who have prostatectomies, particularly for Gleason scores on the high side, the likelihood of more treatment might be down the road. I'm not saying that's the case. You've got a very low jump there. I don't know how many months it took to go from a 0.01 to a 0.04, but it's starting to show up a little bit. And it, you know, you might have another year, or it might stay at that level. How often do you get your PSA tested?
It'll be 3 months is my next time.
Okay, well, all you can do is kind of watch it. Don't freak out, or I don't think you really need to do anything at this point. At some point later down the road, if it does start increasing, you'll probably want to put a medical oncologist on your team rather than just a surgeon, just the urologist, just to help you monitor this and help determine what the possible next step might be. But you're fine. I think you're good. Your numbers are so low that it really doesn't make too much difference. My own jumped from a 0.07 to a 1.6 the last month, and I'm going to get another test done later on this week. So I'm watching mine the same way, and my oncologist is watching it closely too, and just kind of letting me know that the next phase will probably eventually be a scan if it continues to rise, and we'll make a decision then. So no panic.
Well, I'm wondering, do they wait for it to get big enough in order to scan it? I mean, that's what I'm wondering.
Yes, you
if
have
it's
to,
so.
You have to wait till it shows up. You have to wait till a larger number before you can scan. At this point, there's nothing you can really do. Just get that blood test regularly and just keep an eye, but don't panic. You know, you're still at early stages of treatment. Probably the next kind of treatment you might get sometime is some form of radiation, but that could be years down the road. You don't know. So take it easy and just get your blood tests and just eat the right diet, exercise, do everything in your control to manage this, and you'll do fine.
Okay, so thank you so much for that, Peter. I really appreciate that. So can I ask you guys what he said? My doctor said that perhaps we would be looking at IMRT, and I was researching. They have a new radiation called with a proton beam. Do you guys know anything about the difference between those things?
There's very little difference whether you go with IMRT or whether you go with proton beam. They cause different types of side effects. Now, you're going to find a lot of people that are on the forums who are what I call proton beam proselytizers, because they've paid a lot of extra money for proton beam and they're convinced that they've gotten better treatment from it. But the evidence just isn't there. There is a trial going on right now. I haven't seen it published yet. I think it started about 2 years ago, finally, of head-to-head IMRT versus proton beam. But what we do know is that the proton beam appears to have more gastrointestinal side effects versus the IMRT, which has more rectal and anal side effects. So it's going to affect the IMRT is more likely to affect your bowel. The protons are more likely to affect your GI tract. It's more difficult to get proton beam covered because it tends to be more expensive, and there's no evidence that it's really worth it. So that would be my 2 cents. Anybody else want to add anything on proton versus IMRT?
Yeah, I can say something. I worked at the Lawrence Berkeley Laboratory with some cancer research a number of years ago. There is a scientific basis for the advantage of proton therapy, and that is that we would use heavy ions, and heavy ions, that's just an atom with an electron or two removed. They give up their energy at one specific location. That is, they'll penetrate good tissue and not damage it, and then all of a sudden give up their energy. So, in principle, you can spare good tissue by using heavy ions, and a proton is one kind of heavy ion. But like Dick has said, that overall, no one has been able to show that they get better survival with it, and it is more expensive. But there is a scientific basis to the advantage of protons, and that, again, like I say, they'll penetrate your skin and then give up all of their energy at a certain point, so you can better target the tumor. So it's not. Well, anyway, that's it.
Yeah, but what I will say is that because of this action, which is sort of more intense and less penetrative, what people who have experienced proton beam have found is that they have more GI, and I don't know the reason why, but they have more gastrointestinal side effects. Maybe because when the beam is passing through the GI tract to get to the prostate, it's doing more damage, but it doesn't go through the prostate, and it doesn't damage the rectum and the anus in the way that the IMRT can do. I don't know the reason why, but I can tell you, and if you're interested, send me an email, and I will send you the research. But there is good research that shows the difference in these side effects. I don't know. Can you explain why it might be that there's more GI damage from proton beam, Paul?
No, that I can't tell you that.
Okay.
I don't know.
Are we talking about focused radiation, or just talking like the prostate bed?
Oh, we're not talking about SBRT. We're not talking about cyberknife or stereotactic radiation. This would be radiation that could be used on the prostate bed, or the whole pelvic girdle.
Okay.
As opposed to sort of a directed beam, where you would be doing a lot less. You would have a lot less sessions.
Okay. Yeah, because like as Peter said, with such a low PSA, he probably wouldn't show anything on a scan anyway.
Right.
So they're just going to try to do preventative to the prostate bed, perhaps. Yeah.
Right.
I don't have a prostate bed though. That's the thing. So that's wondering then, where would the prostate cells be?
Well, how can you not have a prostate bed?
You don't have a prostate.
I don't have a prostate, so.
Right, but you have a prostate bed where the prostate was.
Yeah.
The prostate bed is where the prostate was lying.
Okay.
Okay. I sent you, by the way, Gary, I sent you a couple of notes in the chat window just to you. You'll see them.
Okay, thanks.
Nothing exciting. Don't get excited about it. It's nothing too important. So anyone else want to give pointers? I mean, to me, the most important thing, Gary, is what Peter said. You've got to just keep doing all the things that are important that you can control yourself, like exercise, diet, stress control, and keep a close watch on those numbers. If you feel you want to be more aggressive, then get a prostate, your PSA tested every 6 weeks. If you're not feeling comfortable with 3 months, and sometimes people have anxiety by having to wait 3 months. Tell them that you want to do it every 6 weeks. I would also stress, I can't stress this enough, that you do not want your urologist handling your disease if there's recurrence. The urologists want to handle this. They feel that they're qualified to handle this, and we invariably recommend that you see a genitourinary medical oncologist, because if you need any sort of systemic treatment, the urologists are just not trained. They're trained as surgeons. They're not trained in internal medicine. So, I think that's just a huge, huge piece of advice to heed. Okay. So anybody else want to say anything to Gary before we move on? Okay. So let's keep going down the list. Ken Anderson, are you there?
Yeah, I'm here.
Hi.
I'm not sure if it's my internet connection, because again, I kind of live out in the country and the connection may not be very good.
Mm-hmm.
No.
Okay. Right now it's great. Right now you're good.
All right. Well,
tell us how you're doing.
Well, of course, Rick, you know I've started that IMRT and I'm about halfway through.
Right.
I finished right around time. I recently sent an email off to Paul Korn asking, because I'm not going to have mentally, I'm not going to have an easy time with doing nothing else after this, radiation therapy treatments are complete, which is right after Thanksgiving. And Paul's reply was that I need to take a well-deserved break and just kind of walk. So,
and what's your response?
I said, hell no. So, I don't know. Pretty long explanation as to why I should. And basically, he's asking me to wait for, and in my head, I think he's asking me to wait for reoccurrence. He doesn't know how long the ADT, how long this Lupron is going to be effective, so he doesn't want to start me on Zytiga until after I have some rise in my PSA.
Mm-hmm.
So, I don't know, it's a difficult thing to kind of put my finger on or hands around.
Mm-hmm. Look, I think this gets into a pretty interesting area, which is that if you're happy with your doc and you trust your doc, then you've just got to go with them if that's what they're telling you. And go ahead.
I wasn't happy about it, but I'm going to do it.
Well, let me throw this one open. How do other people feel when they either want to do more treatment or less treatment than what their doc tells them? Nobody? Come on.
Oh, this is Eric. I have medical oncologists in Berkeley and UCSF, and they've all been very responsive to any requests that I have. So I haven't had any problem with that.
Mm-hmm. And I mean, how do you feel, Eric, about? Are there times when you want to do more treatment that the doctor wants you to do, or there are times when you want to do less treatment than the doctor wants you to do?
Well, I always want as much treatment as I can get. So right now, the Berkeley oncologist is going slowly on the docetaxel because of how sick I got on docetaxel. But more concerned than I am. I'm willing to charge ahead, but so far so good, and so I think that they will increase the. I don't know. I don't know how much. I haven't looked that up yet. What the normal frequency is for
dosage.
Reptana.
Right.
She's doing it every 3 weeks now.
Right, which I think is probably the norm. But look, I'll come back to that. What I want to focus in right now, and Eric, we're going to go next to Jim Cameron, and then we're going to come to you. I'm really want to know, is there anybody that can address Ken's concern that he wants to be more proactive than his dog, but he loves his dog?
Hi, it's Larry. You know, this is what I struggle with all the time in a slightly different situation, but it's back to that I would go ahead with Prevenge, and it's not in the Sloan culture. Last week I saw my doctor. We discussed it one more time. She described that there are some other immunotherapies, you know, coming down the pike, and they haven't opened up any studies yet, but that if you did one, you weren't naive to immunotherapies, you might not be available for the studies. So I have to trust my doc and hold on and not push ahead because I'm very confident with her.
Thanks, Larry. Anyone else want to talk about that? This dilemma that you might have when you have a disagreement with what your doc is recommending?
How about a second?
I think if the doctor's not paying attention to current research, that's a real red flag. I mean, today I felt comfortable that the studies you referred me to, Peter and Rick, that the genetic counselor was very familiar with. And anytime I see a doctor who is just not current, I think then you have to really step into a group like this and ask a lot of questions.
Dennis, I think you wanted to say something.
Yeah, I just said, what about getting a second opinion from another facility, another doc?
Well, I think that's a good suggestion. Ken, in the interim, you could present your case without having. Ken, you could.
I wrapped it up. I took a piece.
Okay, let me just mute Jim
I don't know
Cameron.
if I got it wrapped.
Let me mute Jim Cameron. Jake, can you mute Jim Cameron for me, please? Thanks. Hang on,
I'll get it, Rick.
Okay.
I'll get it, Rick.
I got it. I've got it. So, Ken, there is a doc in Phoenix that I think both I and Dennis Correa would feel comfortable referring you to, whose name is Parminder Singh. He's a genitourinary medical oncologist, and he's at Mayo. And Dennis, do you want to talk about Dr. Singh, because I know you have good feelings about him.
Yes, he was actually my first medical oncologist that I started with after my initial diagnosis of being metastatic. And unfortunately, he left for a better opportunity from Tucson to go up to Mayo. So I kind of had a connection with him prior to this. And so we talked a little bit, and he said, if you think you need to come up to see me, you talk to me, whatever, feel free to do that at whatever point. So as I continued to get my treatments here locally, my Lupron injections and my blood work, and the PSA continued to climb slowly at first, and then it rose on the last 3-month period about 3 times what it was usually going up at. And so when I saw my local oncologist and I asked questions, he was telling me, oh, you're fine, you're doing fine. And this is a guy that I kind of inherited down here when Dr. Singh left. And I didn't have a lot of confidence in him to begin with. He's not in any trials, not doing a lot of research. He's about ready to retire. But I thought, well, just to get my blood work and my Lupron injections, continue to stay here just for the convenience of it. So when this went up and I saw him about it, he didn't think it was an issue. And then we got into a discussion about how he didn't think I trusted him, which I probably didn't, that I should find another doctor. So he kind of almost led me to the making a phone call to Dr. Singh up at Mayo. And he welcomed me and got me in very quickly when I explained to him what my issue was, and proceeded with the flucyclovine scan. And they for sure did diagnose 3 new tumors in progression and some others that I had. So I definitely needed to do something. And so I was glad I went out and got that, second opinion.
So Ken, I personally, and I think others on this call, have great confidence in Paul Korn. I think that, he's second to none. But if you feel that there may be other things that you could do right now, then
really, Rick, that's really not an issue, because he even in his rather long reply, which was he outlined his position, but at the very end he said he would support it. In fact, I wanted to start taking Zytiga. So
okay.
He said instead he would support it. That was my push, even though he felt that it was definitely early. He said if I took Zytiga now, there are a couple of new things in the pipeline that it might exclude me from doing later.
Right.
Now.
Right.
So I heard this before, even tonight, where taking the treatment would not be beneficial long. I'm going to take his advice. He's in this every single day, much more than I.
Right. Well, look, one of the things I really would like you to do, if you haven't done it already, is to listen to the discussion between Alicia Morgan's, Chuck Ryan, and Chris Sweeney, because they talk about the timing of chemotherapy and second-line anti-androgens for people like yourself. And it may help you a little bit decide in your own mind whether you should wait, whether you should proceed. It's about...
I must say, I listened to it.
Oh, you did listen to it. Okay.
Really?
And, I think that that's probably a good guideline, but at the end of the day, it's your decision, whether you want to start now or whether you want to take a bit of a break. But I think you have a great doc. I can't stress that enough. And I think that, he's going to listen to you and to some extent take his lead from you as to what you're ready to do.
Right. And it's a definite work in progress, no doubt.
Mm-hmm. Okay, we're going to move along. Does anybody want to say anything to Ken? Anybody else want to say anything to Ken? Okay. So we're going to move along to Jim Cameron. Jim, bring everybody up to date on your treatment and how you're managing with this tough chemotherapy regime. Hold on, I have to unmute you. Sorry, we were getting some background. Okay, we can, Jim, bring everybody up to date. Are you there?
Can you hear me now?
We can hear you now.
Okay. I had the third infusion last Friday, and so far so good. After the second infusion, I was quite sick for about 10 days. But both Dr. Korn and Dr. Gonder seemed to seem to think it's progressing along, and they expected me to have some difficulty because of they're giving me the 2 chemos at the same time. But right now, as Friday when I was in to visit them and get the 3rd infusion, they're happy with what's going on, and they're going to hold off doing any scans for probably another session or 2. And then I'm going down to see Corn probably after Thanksgiving. I don't want to travel on the Thanksgiving holidays.
Tell us a little bit about these side effects and how you resolved them.
Well, basically, most of the side effects I was having was diarrhea, and they kept changing the treatment, and they seem to have the latest treatment seems to be working pretty well. The only problem is every time they stop the diarrhea, I get constipated, and then we're swinging back and forth. But they say that they say the 1 chemo is famous for causing diarrhea, and they're not surprised.
Is that the carboplatin?
No, it's the other one.
Oh, the docetaxel.
Docetaxel. They've had a lot of diarrhea. Almost everybody that's been on it had diarrhea problems. And believe me, beginning of last week, it was terrible. But they upped the pills I was on, and it seems to have calmed it down quite a bit.
So who else has suffered from diarrhea as a result of being on docetaxel? Any of you?
Yeah, this is Jim Harrington. Yes, I do. I'm in about 2 months of docetaxel, and I do very well with it. But I agree with Jim that it can certainly be a problem, and it's generally in the first phase when I hit the nadir. After that, and it can come on. It usually starts off soft stools and then winds up in a bit of diarrhea, and then I take the Imodium. I don't know, maybe take the Imodium before, but I don't want to get constipated. But yeah, I've dealt with it, and I don't know what to say, Jim. I wish it. I mean, I just had an infusion today, and I expect maybe some diarrhea. I think it's gotten a little bit worse, but yeah, it just seems to come with the territory with this. Otherwise, the docetaxel is not bothering me, and it's keeping my PSA sort of slightly going down. So, but yeah, I talked to my nurse today. I was in the Cancer Institute today, and about this, and they just sort of shrugged their shoulders. Go on, watch the food you eat, and for diarrhea, it can make a difference. You should stay off high fiber foods, like whole grains, and stay off of milk. Yogurt's okay. And that's hard to do in some ways, but I think it makes some sense.
Jim, that's basically the same advice I'm getting from the nurses and the doctors.
Yeah, the nurses, yeah. I mean, I don't know how it just sort of comes on. I just always hope that when it happens that I'm sort of near a bathroom and not in some place where I'm not. But I think I've had a little bit more diarrhea in this. I've had about 2 months of docetaxel than I did in the begining, but how many you deal with it.
That so far, Jim?
What's that? The docetaxel. It's just like you, Jim. I've just become hormone resistant. I got bone mets. The cancer has moved into my liver and my lungs a little bit, but my results today of my scans were very good. It's starting to work, but it doesn't just kill all the cancer. Not for me anyway. But I just will stay on it, and I don't know how long. So it's the same, I guess, as you. It's just that, they've done CT scans and they see a mass or a small mass in the liver and lymph nodes in the lungs. So
I don't have anything as of the last one. I don't have anything in the lungs, but I have liver problems, and of course I have the spindle cell.
Yeah. Do you have bone mets too? Do you have bone mets? No bone mets? I got bone mets all up and down my spine. I got bone mets all over the place, and I look at the bone scans, and I just light up like a Christmas tree. But I have no pain. It's my PSA is about 3.5, and it's puzzling. But I've had these bone mets for a long time, and my doctor in the Cancer Institute just likes to punch me in the back. And he said to me, "You don't have any pain," and then he punches me again, but I don't. And so that's good news. I'm just one of these people that doesn't have pain from these things, and my PSA is low, and so yeah. I mean, what are you going to do? You get bone mets. They seem to be getting a little bit better according to the scans.
Jim Cameron, what medication are you taking for your diarrhea?
I'd have to go get it.
Did they give you a prescription, Jim, for that?
Yes, they did. They gave me a prescription. Yes.
Oh, because I don't have one. I've not tried it. Does it? Okay. Yeah, it'd be interesting to know what it is. I don't know about.
Hold on. I have to go in the other room and get it.
Okay. So,
Well, I don't know. I mean, it's a problem. What are you gonna do? I mean, it's not great.
Yeah, no, I'm curious if he's getting Imodium or if
I don't.
getting
Imodium is
something
just.
else.
I mean, anybody can get that, and then by the time I get into the diarrhea stage, then take it. It seems like the horses are out of the gate, But then I get no more diarrhea after I take Imodium.
Mm-hmm. Has anybody else on the call had significant issues with diarrhea from chemotherapy? Larry Fish or Dennis Correa or anyone else who's had chemo?
Yeah,
Jim, they did have me on the Imodium at first. Okay, I'm going to spell this for you. It's DIPHENLATE/ATROPINE tablets.
Okay, diphenyl oxalate atropine. So, Dennis, did you want to say anything about this diarrhea issue?
Yeah, my supportive care doc, when I was doing the chemo, suggested a probiotic, and it worked pretty good. I didn't have really any significant diarrhea, maybe once or twice, a little bit, but it wasn't persistent. And I'm still using that probiotic, and boy, I'll tell you, it keeps me as regular as clockwork.
Yeah, that's been suggested to me too. I haven't tried it, but I think probiotics can always be good. Which one do you take?
It's by Claire Labs, Klair. I believe it's spelled, and it's Vital 10. Is the product.
You buy it over the counter, don't you?
Yeah. I buy it from.
You buy it at Whole Foods. Whole Foods has a lot of probiotics.
I don't know. This one I get at a local clinic, but I just walk in there and purchase it. There's no prescription necessary or anything. Okay. You can buy it on mail order also. Let me see if I give you the website here if I can see it. No. Somebody did say it was a bit. You could buy it on.
There's a lot of probiotics. I mean, as I say, Whole Foods or health food stores. So all kinds of and buying certain levels of the good bacteria or whatever it's doing.
Yeah, you could just search that. It's called Vital 10, VITAL.
Okay.
And it's
thanks.
KLAIRE Labs.
Okay, thank you.
Okay, so I want to just Jim, is there anything else you'd like to talk about before we go to Eric? Jim Cameron.
Talking to me?
Yeah, Jim Cameron.
No, it's just that the going back and forth with the diarrhea and the constipation is a little maddening at times,
Have they? When are they? What's your PSA or your scans? Because you've had 3 sessions now.
Well, because I was having trouble sitting because of the spindle cell, and that has subsided substantially, and I was getting tremendous burning, and that has gone away about 95%. Both the doctors they want to wait for another set. They're going to wait. They think something. They like what they see, so they want to hold off another round before they do the scans.
Okay.
And closer till I go down to Anderson.
And what about your PSA?
I don't know. I don't know what the PSA is.
Okay. It might be good.
They test me every. I go in every Friday for blood tests and all.
Okay. Well, it may be good just to know what your PSA is to see if there's any indicators that it's working. So, just as a thought.
Yeah, I agree with that.
Okay, we're gonna move along finally and get to Eric. Eric, tell us how you're doing on this new regime. I mean, they switched you from docetaxel to Jevtana, is that correct? Are you with us, Eric?
I'm sorry, I was double muted.
Okay.
Can you hear me now?
We can hear you. So did they switch you from docetaxel to Jevtana?
No, from carboplatin.
Oh, you were just getting pure carboplatin and nothing with it?
Right.
Okay.
Right now they're giving both.
Oh, now they're giving you Jevtana plus carboplatin. Okay.
Right. They were worried because of how sick I got on the docetaxel that I would get extremely sick, and the carboplatin I didn't have any problems with at all.
Good.
The Jevtana, I am having some diarrhea and other problems. I've only had one, so usually it's the second one that gets you. But so far I haven't lost weight. I have had diarrhea, but not severe. And they're doing, as I said, they're doing it every 3 weeks. They're going to do a scan. I did have the radiation with the CyberKnife.
Right.
And that did relieve. I was having terrible back pains, and that did relieve that.
Oh, great.
So at least
good.
At least in the short term.
Good.
So,
out of the office.
as I said, my oncologist is leaving Sutter, so now I have to figure out what to do. But I'll continue on this regime, and see if it works. If it doesn't, then I'm back to UC anyway. So, I'll go back to Dr. Agarwal.
So in other words, you're saying you would stay. You'll stay with this doc as long as she's there, and then you will move back to Agarwal. Is that your plan right now?
Yes.
Okay.
I will continue to get my treatments in Berkeley.
Right.
Yeah, it was the having the radiation, 10 days in a row, and driving to Parnassus every day for 15 minutes. 2-hour round trip for a 15-minute appointment.
Yeah, it's frustrating.
That's still better than some people. There was one of the guys was driving from Ukiah. So,
Oy.
Yeah.
Oh my gosh. Have you seen any changes in your PSA or your alkaline phosphatase?
My PSA is doubling every 6 weeks. I'm now up at 50.
Okay. So has it been doubling since you started the chemotherapy?
Well, as I said, I've only had one session, which was last Wednesday. So I haven't had a PSA since then. So I'll get one of those in 2 weeks. I'll get the full medical workup in 2 weeks, and then if everything's okay, then I'll get another round of chemo. But,
right. But when did you get your first lot of carboplatin? That was a while ago, I thought. Only carboplatin.
Right. Yeah, I've been getting carboplatin weekly for 4 sessions.
And
I've only had 4 sessions.
Right. So my question is, has your PSA been doubling whilst you've been getting the carboplatin?
Yes.
It has. Okay. Okay.
Yep.
Okay.
So that's discouraging.
Yes. But let's hope that by adding the Jeff Tanner that we're going to see a result.
Right.
Any questions for us, or does anybody want to say anything to Eric?
Well, I wanted to talk about somebody, Paul Frieda asked me about my pain, and
right.
So the pain was quite heavy, and I was taking MS Contin 30 milligrams 3 times a day. So I've cut that down to a 15 of MS Contin in the evening, and in the morning I take a 10 OxyContin, and I'm trying to cut down on it, and I did have withdrawal symptoms pretty quickly, so I just took going slowly. So it wasn't, I actually what happened was I forgot to take my MS Contin one morning, and around 3 o'clock in the afternoon, I started having all these symptoms of what's going on, and I realized that I'd forgotten it, and so I was getting withdrawal symptoms, but I'm not on very much of it, so I think I should be able to cut back if I do it slowly.
Okay, well, I'm really pleased. We're all really pleased to hear that your back pain, that horrible back pain, got relieved with the last lot of spot radiation. How many sessions did you have? 10, was it?
10. Yeah, 10.
Yeah, right. Anybody else? Anybody want to say anything to? Like to say anything to Eric?
I have a question. What kind of symptoms do you have when you have withdrawal?
I get very anxious. I get nervous. I get cramps. I get shaky. I feel like I'm on the verge of a panic attack.
Oh, okay.
Just edgy and
that was after one day. That was just after one day. Or
yeah,
5 or 6 hours.
I missed the dose entirely, and it was, it was a number of hours before it happened. But I did have one other horrible symptom, which was a couple of days ago. I was cooking dinner, and my left leg quit working right. I couldn't walk. It just wouldn't hold my weight, and that was pretty scary. I was convinced that was the beginning of the end of being able to, not have perhaps paralysis coming on, because that's the most danger. The tumor I have is wrapped completely around the spinal cord, one of them. So, it's. If it starts affecting the spinal cord, then I will have major problems. That's one of the reasons why they did all the fiber knife radiation, was to move the tumors away from the spinal cord.
Right.
That was pretty scary.
Is that when you fell in the driveway also?
It was around the same time, yeah.
Yeah.
Did your leg just give out on you when you fell, Eric?
No, the one the big bruise on the face, I actually tripped over. There was a little concrete barrier, and I tripped over it. And I had my hands full, so I couldn't. I tried to catch myself, but I couldn't quite catch myself. And then I hit up a bit against the concrete abutment, and that's what did the damage.
That's my special.
It's not nearly as painful as it looks.
Good. Okay. Well,
I'm glad to hear that.
I'm the one that's expert at tripping over my own feet. So
Oh dear.
So you know, I empathize greatly with you, and I sympathize as far as the pain is concerned.
The other thing just quickly, the other thing that's happened to me is that I have less and less bladder control. Unfortunately, that's a disturbing thing because it's, you know, it affects anything social that I do. I have to always be sure that I can get to a bathroom nearby.
Have you discussed that issue with your? I mean, do you still have a urologist on board or not?
Yes, I do.
And have you discussed this bladder? I would.
But yeah. So far, they wanted to send me to PT, but yeah, I haven't done the PT yet.
Okay. And there are meds. I mean, I know you rattle when you move, but there are meds, and they may be able to help you with some meds. So don't suffer there, especially if it's impinging on your social calendar, and which you know you need to feel good.
Okay. Yeah, I'll hit them up next week.
Okay. Well, guys, it's 7:04. I'm going to cut it off at this point. But this has been an excellent session. We've talked about 1, 2, 3, 4, 5, 6, 7, 8, 9. We've covered 9 different topics at least today, which for us is pretty good. Because I keep a record so that I can make notes for the when I post this, and you know, and that excellent discussion we had up front about quality versus quantity and leading your docs. So thank you, everybody. The next session will be a week from tomorrow. If we have the time in that session, I will do a brief summary of what I learned on Wednesday at UCSF. I'll let you know if there's anything startling, provided I understand what they talk about. And I'll just say good night to everybody and wish you all very, very well. Good night.
Good night.
Rick, can you hold on a sec?
Yes, I can.
Don't forget Inner Conversations on Thursday.
Oh, yes. Don't forget Inner Conversations on Thursday. Definitely. Okay, guys.